Thank you, Dan, for that very nice introduction. I have always been that guy. Medical school, college, high school, and even in my own household, I drove my parents crazy with all my questions. So now I'm very happy to talk about some of our work in vitiligo. And specifically, we'll talk about translational research in vitiligo, what it means for understanding vitiligo pathogenesis, as well as potential new targeted therapies. These are my disclosures. And I will be discussing off-label drug uses because there are no FDA-approved treatments for vitiligo. I always like to start with a slide. This is my grandmother. She had vitiligo. I did it with a... She had vitiligo here on her elbow and her arms. Her brother also had vitiligo. This is a very common disease. Up to 1% of the population has it. And in fact, my shuttle driver on the way from the airport had vitiligo, just on my way to the SID. That means up to 3 million patients have vitiligo in the US. That's 70 million people in the world. The annual estimated cost burden is about $175 million. That's despite not having any FDA-approved therapies. And in stark contrast to psoriasis, which is a $12 billion a year industry. Half the patients who get vitiligo do so before the age of 20, and they have it for the rest of their lives. So this is a chronic, long-term disease. This is how it begins. You can see it's small macules of depigmentation that then expand and coalesce into larger macules and patches of depigmentation. And this is a typical presentation on the hands of a patient. When I first started to see patients with vitiligo, I was really interested in the fact that it was so patchy. And one of the questions was, why did the patch choose to appear here and not right next door? And this patient may have this patch for the rest of her life and have no involvement of the dorsal hand. So that was some of the questions that drove our research. So we wanted to better understand what was happening in vitiligo. We and many others before me have done a number of fantastic studies using translational research, human tissues, to better understand what's driving this pathogenesis. In the early 1960s, a number of clinicians recognized that vitiligo appeared with autoimmune diseases, suggesting that it itself was an autoimmune disease. In the 70s and 80s, there are a number of studies that reported that melanocyte-specific antibodies were elevated in patients with vitiligo. And in fact, this study in 1977 was Steve Katz. He was one of the first to study vitiligo. We had a conversation about this yesterday. He actually enrolled a number of autoimmune syndrome patients, APESED syndrome patients with vitiligo, and found that they had elevated antibodies. And these antibodies were complement-fixing antibodies. But in the 1990s, people started culturing melanocytes from human skin. And this was relatively easy to do from healthy patients without vitiligo. But patients with vitiligo, their melanocytes didn't grow well. They grew slowly. They appeared sick in the dish. Their endoplasmic reticulum appeared dilated, and so that looks like cellular stress was elevated in these cells. And then if you added extra stress to the cells with peroxide or any other oxidative stressor, healthy melanocytes tolerated that just fine, but melanocytes from vitiligo patients died. And so this strongly suggested that there were intrinsic defects in melanocytes, in addition to this what we thought was an autoimmune response. And in fact, a number of people thought that this was really all that was going on. It was a degenerative syndrome. There was no real autoimmunity occurring. And these were important observations, and I think Mauro Picardo is probably in the audience. He was one of the key contributors to this. Actually, a number of people sitting in the audience have contributed to vitiligo research over the years. But in the 1990s, Caroline LaPoule and a number of her colleagues histologically looked at vitiligo lesions and found that there was a strong T-cell infiltrate, and these T-cells were co-localizing with dying melanocytes. And the T-cells were, in fact, CD8 positive, so these were cytotoxic T-cells, which made sense because cytotoxic T-cells kill cells. And so it started to suggest that autoimmunity did indeed play a role in vitiligo. And then in 2009, an important study was done by Jasper Vandenborn, first author, and Rosalie Luton, senior, where they actually took lesional skin from vitiligo, cultured the T-cells out of that skin, and then co-cultured the T-cells with normally pigmented skin from the same patient. the T cells crawled into that skin and induced apoptosis and melanocytes. So this fulfilled Koch's postulates for something that causes a disease. The causative agent was isolated out of diseased skin, introduced to undiseased skin, and it caused disease in that skin. So this further implicated CD8 T cells in particular, because if you depleted CD8 T cells from this pool, nothing happened. But if you enriched for CD8 T cells, it was an even more vigorous response. So this showed that CD8 T cells in vitiligo are both necessary and sufficient melanocytes. Genetic studies over the past 5 to 10 years have told us a lot. A number of groups all over the world have identified a number of risk alleles for vitiligo. This is summarized by Richard Spritz here. And most of the genes fall in immune pathways, strongly implicating the immune system in causing vitiligo. A large number of genes are adaptive immune genes. There are a number of genes that are innate immune genes. But in addition to that, there are melanocyte-specific genes involved in melanogenesis, and XBP1 as well, which is involved in the cellular stress pathway. So this started to tie everything together and suggest really that all of these pathways may be important in vitiligo. And the question was really how to tie them together. So how can melanocyte intrinsic defects, sick melanocytes, work with autoimmunity really to drive vitiligo? And this is the current state of thinking in terms of how they all tie together. So melanocytes from vitiligo patients appear to have higher levels of stress. Melanogenesis itself contributes to that, but genetic factors and environmental exposures can exacerbate that. And then stressed melanocytes actually produce and secrete danger signals that then activate nearby immune cells to induce inflammation. And this inflammation recruits T cells. The T cells come in to the skin, find the melanocytes, and kill them. And so this is really the current idea. First proposes the convergence theory many, many years ago, and we've learned a lot more to help tie that together. So there's a lot going on in vitiligo. And despite that, though, we do have some treatments that are somewhat effective. And this is the goal of treatment. It's to regain our pigment, so to get melanocytes to regenerate in the skin. And fortunately, that happens if you're able to shut off the vitiligo response. And the melanocytes are regenerated in a perifollicular pattern, showing that they're coming from the hair follicles themselves. And this is most likely due to the fact that melanocyte stem cells, there's a stem cell reservoir that resides in the hair follicle, and the hair follicle has immune privilege, which probably protects those melanocytes. So if you're able to shut off the disease, you can get repigmentation. And this is just an example of a patient whose entire abdomen was white. And through this perifollicular repigmentation and growth over time, he was able to erase his lesion. And so when we're thinking about current treatments, but even more importantly for new treatments, we want to think about all of these pathways that are contributing to vitiligo and play a role in the response to treatment. So melanocyte stress, we think, initiates the whole process. That activates autoimmunity, which induces progression of disease through destruction of melanocytes. And then even if we were able to take care of these things, patients are left with white spots, and we need to promote melanocyte regeneration. Now, fortunately, melanocytes kind of want to regenerate and regrow and repigment the skin anyway on their own, but if this could be encouraged, that would be an even better treatment. So current treatments include topical steroids. They're typically first line, topical steroids, topical calcineurin inhibitors, and they suppress the immune response, and they induce repigmentation. So that's a good beginning, good start. More recently, people have developed techniques, surgical techniques, to transplant melanocytes to depigmented skin. And this is highly effective, but only for patients with very stable disease. So if there's any active autoimmunity during vitiligo, transplanting new melanocytes to lesions doesn't help because they just get destroyed right away. So a small population benefit from this transplantation surgery. And then finally, narrowband UVB is probably the best treatment we can offer patients currently. And it's highly effective, well, it's more effective than topical steroids, probably because it suppresses autoimmunity, it's immunotolerant, and then also promotes melanocyte regeneration in the skin. So the pathogenesis of vitiligo and understanding better treatments, we need to really understand all three of these pathways. And I encourage you to check out a number of posters that are here on vitiligo. And they cover kind of the whole spectrum, and so it's really encouraging to see lots of people studying this process. We're going to focus more on autoimmunity specifically for the rest of the talk, and that's primarily what we do in the lab, and we hope to identify new treatments through that. So this is a patient who had widespread vitiligo, who came into my clinic, but also a kidney transplant. So he was highly immunosuppressed, and he repigmented better than any patient I've ever seen. And so this really suggested that if we could significantly immunosuppress our patients, they would do well, at least in their skin in terms of pigment. But this is a level of immunosuppression that we're not willing to go to for really any disease other than kidney transplantation, which is directly life-threatening. But the idea came that if we could identify the pathway, just one pathway that drives vitiligo, and it's critically responsible for vitiligo, then we could target that one pathway and develop a therapy that's both high efficacy and safe. And this is what we've done in psoriasis. We've seen great responses in psoriasis targeting one pathway, TNF-alpha, and then IL-17. If we could do a similar thing in vitiligo, that would be fantastic. Currently, TNF-alpha inhibitors have been tested in vitiligo, and so far we see no real efficacy, suggesting that it's a different pathway that drives vitiligo than drives psoriasis. And so we were interested in trying to find that pathway. And to do so, we wanted to develop a mouse model of vitiligo. Dan mentioned that we worked on this I worked on this when I was at Penn, developing it. And the problem with mice is that even B6 mice, which have very black hair, have pink skin. They have very few melanocytes in their epidermis. And so existing models of vitiligo, when we started looking into this process, really consisted of depigmentation of the hair, not the skin. And most of the mouse models that had been developed for vitiligo were melanoma immunotherapy kind of side effects. So melanoma would be injected, and then they'd give the T cells and shrink the melanoma, and also the mice would get white hair. So we wanted to try to develop a mouse model of vitiligo that consisted of epidermal depigmentation. And I'm very thankful to Jack Longley, I think I see you right in the center, for letting us have these mice, which are transgenic mice that have both black hair and black skin. They express stem cell factor, or KIT ligand, under the keratin 14 promoter, which retains melanocytes in the epidermis during development. And so this is much more like human disease. The melanocytes are both in the hair follicle and in the skin. And we use these mice as hosts to induce vitiligo. Importantly, I think Jack made two versions of these mice. One version where it used wild-type stem cell factor, which could be cleaved, and then another version where it could not be cleaved. And the cleavable one induces mastocytosis at the same time, and this non-cleavable one just induces melanocyte retention in the epidermis. So this is what we use. And so we modified a protocol developed by Nick Restifo for melanoma immunotherapy. Taking these black mice, we sublethally irradiate the mice. We adoptively transfer in 1 million of CD8 T cells that recognize melanocytes. In fact, they recognize GP100, a melanocyte-specific antigen. And then we activate those T cells by IP injection of vaccinia virus that expresses their antigen. And then we follow the mice over time. What we see on the left is our control mice. What we see is patchy depigmentation here on the ears of the mice. We see it on the nose, on the feet, and on the tail. And so it looks a lot like human disease. And our next step was really to look at the gene expression in mouse lesions and also human vitiligo lesions to try to identify which inflammatory pathways were turned on and really driving this disease. So when we did that, here I have human expression in black bars and mouse expression in white bars. We're very happy to see that it looked very similar. So we saw the same genes in both mouse and the mouse model and humans. We saw loss of melanocytes, which we were expecting to see, and that was encouraging. And then what we saw was really just one pathway. One inflammatory pathway was activated, and this was the interferon gamma-driven pathway. So we saw really no representation from the Th2 pathway, nothing from the Th17 pathway. In fact, P19 was suppressed in human vitiligo skin at a high level. And importantly, while we saw interferon gamma, we didn't see type 1 interferon. So we didn't see any interferon alpha or interferon beta produced. And this strongly suggested that interferon gamma was driving this process. And that if we hypothesized that if we target that pathway, shut just that one pathway off, we might be able to treat vitiligo safely. And so that was the case in our mouse model. We showed that if we treated the mice with interferon gamma neutralizing antibody, we could prevent disease onset. And so we were satisfied that interferon gamma was really responsible in the mouse model for driving disease. And then in addition, we found that the T cells in these mice were not finding their way into the skin. So if you block interferon gamma, the T cells are still there in the lymph nodes and the spleen and the blood. They're happy, but they never made it into the skin, strongly suggesting that interferon gamma was inducing a localization signal. And we hypothesized that CXCL9 and CXCL10 might be the downstream effectors of interferon gamma for this process. They're both interferon gamma induced. They both promote recruitment of T cells into peripheral tissues. And they were the highest expressed genes in both human and lesional skin and mouse lesional skin. So we thought that this was probably a good pathway to take a closer look at. Both of these chemokines signal through the chemokine receptor CXCR3. And so we looked at CXCR3 expression in patients with vitiligo. We knew that the chemokines were up in the skin. So then we took blood and we used HLA tetramers to identify, by flow cytometry, identify melanocyte-specific autoreactive T cells. And we found that in vitiligo patients, those T cells preferentially expressed CXCR3. So those T cells were capable of responding to that chemokine that was being expressed in the skin. And then we also found by histology that CXCR3 was expressed on the T cells in lesional skin. And so in humans, we also saw this pathway highly activated. So we jumped back to the mice, and we adoptively transferred in T cells to try to induce vitiligo, but with T cells that lack CXCR3. We found that the mice were protected from vitiligo. They developed very little depigmentation, suggesting that the T cells really needed CXCR3 to get into the skin and cause disease. We also found that the T cells, this is skin flow cytometry, we found that the T cells had a hard time getting into the skin, but again, in the lymph nodes, they were there in normal numbers. So this was really, we believed, a T cell recruitment thing that was occurring. We then found, the question was whether CXCL9 and 10 were redundant. They both signal through the same receptor, so they could potentially be redundant. But we found that CXCL9 knockouts developed normal disease, where CXCL10 knockouts were highly protected. And then to showing that CXCL10 really was the major player in disease pathogenesis. So then we wanted to know whether we could test this in a treatment-relevant way and actually block CXCL10 with antibody rather than knockout. And that worked as well. So if we neutralize CXCL10 with an antibody, we could prevent disease onset as well, consistent with the knockout results. However, this is not that useful to patients in the clinic. I rarely have a patient come into clinic saying, I think I'm going to get vitiligo next year. Can you give me something to prevent that? So really good treatments for vitiligo can't just prevent new spots, but they have to repigment what's there. And honestly, we didn't have a lot of hope that CXCL10 would work to repigment spots, because we felt like once the spot was there, once you had a white spot, the T cells were there and gone, and you wouldn't need CXCL10, that we'd have to combine this with another therapy. We were a little surprised to find that, in fact, treating established depigmentation in mice reversed disease. So once we took these mice with white tails and we started treating them with CXCL10 antibody, we got perifollicular repigmentation in the mice, just like we see in the humans, showing that blocking CXCL10 could also reverse vitiligo. This was very exciting in terms of treatment. So we hypothesized that targeting this pathway, CXCL10 and others, not only will prevent disease, but reverse it, and this could be a viable treatment in the future. But this was, again, really kind of surprising. We had this white tail, and you needed CXCL10 and active T cell recruitment to keep it white. And so my postdoc, Jillian Richmond, great postdoc, will be presenting what we think is the answer why. I'm not going to talk about why we think CXCL10 is required to maintain vitiligo lesions, but she's giving an oral presentation on Saturday in the mini Symposium 12. I encourage you to check it out. So based on targeting this pathway and seeing its efficacy, we thought that maybe blocking STAT1 could be an effective treatment. So STAT1 is required for interferon gamma signaling. It's downstream of the JAKs, and it's responsible for the signaling and chemokine induction. And I was at an SID, I think in 2009, where I saw Erwin McLean give a talk, and he was talking about doing a small molecule screen to block STAT1 activation. And so I went up to him after his talk and asked him if he could let me know what he found, because we'd be able to use that too. And he was really nice and told us that statins were major inhibitors of STAT1 activation. So HMG CoRe reductase inhibitors, and particularly simvastatin, was blocked STAT1 activation. So I literally ran back up to my hotel room, and I was looking on PubMed to see if anybody had tried this before. And there was one case report of a guy who had hypercholesterolemia and vitiligo. He got high-dose simvastatin, and his vitiligo repigmented very, very quickly. And so we were really excited. We then bought simvastatin and gave it to our mice, and it worked great. So we just published this result this year. It both prevented vitiligo and was able to reverse disease, not quite to the same extent as blocking CXCL10, but nonetheless had an effect. So for future studies, we want to look at this pathway and further target this pathway in humans for treatment for vitiligo. There are a lot of options. And that's it. I'm thankful for the Dermatology Foundation for supporting me significantly, most recently with the Stiefel Scholar Award, which has supported much of this work. And then these are the people in the lab who actually did the work. Mady found CXCL10 was required for vitiligo initially. Jillian did all the REX3 work and all the functional studies, reporter work. Preeti did the simvastatin studies, and Kingsley's working on the role of Tregs in vitiligo. And then my collaborators, Amit Pandya and those at Genzyme, helped a lot with the tissue staining and acquiring tissues. And that's it. Thank you very much.